And good evening. Respected physicians, today is our 109th session of lecture series from ECG Study Group, ECG Basic and Beyond. And today we have amongst us none other than Dr. Rafique Ahmed sir. As usual, before the start of the lecture session, I'd like to request Professor Abdul sir to say a few words about our most renowned and popular Dr. Rafique Ahmed sir. And then we start the lecture session. Jamil sir.
Assalamu alaikum. Thank you, Tushar. Rafique sir is a great teacher, no doubt about it. And I learned so many things from him since 2004, after I came back from EP training from Delhi. And since then, we met several times and we had workshops together. And in between the cases, he used to take some lectures also on different cardiac electrophysiology. And he is always a great teacher. He can deliver very complex things in easy way, and which is very needed for the learners to catch up those things. And let's see, and let's hear today again about ECG again. Thank you, sir.
Thank you. So, Assalamu alaikum and good evening there, right, Bangladesh. So today, I'm going to go over some ECGs, not many, some, and what I want is the participants to answer. Don't worry whether you are right or wrong, but don't answer randomly. Answer something, you look at the ECG and you say, this is what it is. I don't care if it is right or wrong, but I want an answer which you think is the correct answer. So I'm going to start with the first ECG. So this is one. So please look at the ECG and decide. There are 4 choices in each ECG.
Okay. Kamal bhai, keep the poll open for 30 seconds.
Then what I would like to do is, if possible, at least get 1 or 2 participants and talk about it instead of us. Okay. Only 1 person answered. Can we have more answers, please? Let's put the poll again. I want a few more answers.
Sir, sir, I have my answer. Can I answer it?
No, you cannot answer. You are the.
No,
I want the participant.
No, sir. I want to give it. Okay, there's a much. Okay, sir.
All right.
I want to put it in as a participant's perspective, not as a.
No. Who is the participant?
Now the participants are, as they are not responding in spontaneously.
No. They're responding.
They responded a little bit.
They responded.
Okay. Now they responded. Okay.
Yeah. So we have basically 10 people answered, which is excellent, and we have a broad spectrum of answers. So Is it possible to get at least one participant to come and talk about it?
Please respond someone if spontaneously. Just raise your hand in the chat box so that we can have your answer.
And it's going to away.
Tunajina Afrin Khan, can you please unmute and say? Dr. Tunajina?
I think it is atrial fibrillation with RBBB.
Okay. And why do you think that the other answers are wrong?
Obviously, it is a right bundle branch block.
Okay, great.
I can see some fibrillatory wave there, and the rhythm is not regular, obviously.
Yep. Okay. So that's interesting. It's a wide QRS tachycardia. So it could have been ventricular tachycardia or any of those choices. But it is irregular and it is irregularly irregular. So it is most likely atrial fibrillation with right bundle branch block. And I'm going to come to this, why it is not ventricular tachycardia. First of all, the morphology and other things.
Sir,
anybody else, any comment?
Sir, can I add one comment?
Sure.
There is also electrical alternates in the rhythm strip that goes in favor of atrial fibrillation.
Yep.
Sir, can I raise a question?
Sure.
That is, if someone put ventricular tachycardia as answer, or in practical life, if someone treat this as ventricular tachycardia, what are the adverse outcome? What is the danger?
Okay. I mean, it can be considered as ventricular tachycardia. And one of the problem will be that, especially in this case, let's say you assume this is ventricular tachycardia, patient is in the emergency room and you cardiovert the person. So now you are cardioverting somebody who is 87-year-old with atrial fibrillation to sinus rhythm, and you will carry high risk of stroke.
And
So,
also another point, Dr. Rafique, Dr. Ahmed, if you assume that it's AFib, then anticoagulation would be made. If there's no other factors are available, anticoagulation immediately do that before you even consider, that you mentioned cardioversion. So the management plan is VT, then we are not concerned about anticoagulation, but it's AFib, yes.
So anybody, any other comment? So if nothing, then I'm going to go to the
Sir,
next.
what would be your drug of choice for controlling the rate in this patient?
The rate control, it depends on the hemodynamic stability of the person. I'm assuming patient got a 12 lead. If the blood pressure is good, we start with beta blocker or calcium channel blocker. And the heart rate is not very fast. I mean, it is fast, but to me, it's not very fast. 150, I'm sure that if you give a beta blocker or calcium channel blocker, the heart rate will come down. So that will be our primary choice. We will not, I don't give amiodarone for rate control. There is a reflex to give amiodarone. I'm sure Wadud probably is alluding to that a little bit.
I mean, sir, I was actually referring there for that purpose, because people are using too much amiodarone for this type of patients.
Yes, yes. And it is true even here in the United States, because in the emergency room, people always want to go to the safest route. But the drug is toxic, drug is expensive. So we have to consider that. So amiodarone is not a drug that we use for rate control. Next one. So because we had the other one, so I decided to put this one. This also has right bundle morphology. and then we can come back to the other one. So, poll, please. Again, I would like to request everybody to answer.
Sir, I'd like to request you one thing. In all the cases, my question will be that if someone takes the wrong choice, what is the harm in it?
We'll talk about it.
So if we can discuss what is the harm in diagnosing the wrong or assessing it in the wrong way, what is the harm in it?
Can you put the poll up, please?
Amul bhai, keep the poll for 30 seconds.
I would like everybody to, so this is a 46-year-old female with diabetes, hypertension. And the only symptom was she was not feeling well for last 7 days. And no chest pain, shortness of breath, palpitation, dizziness. And this is the ECG. Just feeling of being not feeling well. Okay. So we have majority say supraventricular tachycardia, 1% ventricular tachycardia, and I'd like one of the participants who called it supraventricular tachycardia and explain this to me, please. Tushar, can you?
Sir, if you consider the clinical background, it said the young woman with...
No. I'm not asking you to answer that. I want somebody who answered it as supraventricular tachycardia, one of the participants.
Sajjad. Dr. Sajjad, please unmute. Put your answer. Unfortunately, we can't get him.
Is Maisha online? Tushar?
He is not online. I think she has duties in
Okay,
hospital.
anybody else want to talk about it? I think supraventricular tachycardia is a reasonable choice because if you look at lead 1, it looks fairly narrow. And so I'd like at least one participant to come up and talk about it. Nobody?
Dr. Tunajina, are you here? Dr. Tunajina, can you please unmute?
Yes. What I can say this, the rhythm is regular. The P wave seems to be coming after every QRS. And as the QRS are wide, but there is not, all the leads are not in the concordance which goes in, which corresponds to the VT. So I think it's a supraventricular tachycardia with bundle branch block.
Okay. Nobody else? So yeah. So actually, you are spot on, except for the diagnosis. So it's a regular tachycardia. In lead 1 looks narrow, but if you look at lead V1 looks wide, it's right bundle. But you're absolutely right. Look at this. If you look at in lead, inferior lead, there is a QRS and there is a retrograde P wave. And that's what I thought initially. But look at this. I moved along and then I picked up this area retrograde, no retrograde, retrograde. See, there is a P wave here, there is a P wave here, but there is none. So that goes against supraventricular tachycardia. That goes a little bit in favor of ventricular tachycardia.
So,
and then, any panelist, any comment?
yeah,
Sir.
I have one comment, Dr. Ahmed. I know that the QRS morphology in view 1, the first segment is definitely higher than the second segment. But another question we have, purely like if it's AV nodal reentry, sometimes you can have blocked retrograde P wave. Because if it is blocked but tachycardia continues, that tells me that it is in the AV node. Because sometimes you see retrograde P wave and you might not see some P wave, but every other beat is concerning. But sometimes we see some AV nodal reentry, some retrograde P wave is blocked.
Yeah. So the question is, what Dr. Hawk is pointing out is, if we have AV node reentry, there can be retrograde block or sometimes anti. Actually, retrograde block in AV node reentry is very rare. It's antigrade block that you can get more often than retrograde. Second, because in retrograde, there is nothing to block because their AV node is the circuit, and in the atrium, there is not much tissue, but antigrade there can be blocked. But let's say that's a possibility. We assume that this is AV node reentry. But look at the morphology of the QRS complex. If you look at lead V1, initial R bigger than the second R is in favor of VT.
VT, yes.
Rafique, let's
So, yes, so look at the morphology of the VT. So if white QRS tachycardia is of right bundle, this is the morphology pattern we look at. If it is positive, all positive favors VT, which it is. QR or RS pattern favors VT. In V6, if the RS ratio is less than 1, look at here. The R is small, S is so deep that this favors ventricular tachycardia.
Sir.
So it fulfills multiple of those criteria. One, retrograde, AV dissociation, secondly, morphology criteria. So no question, this is VT. So what happened to this patient? So this is when the patient converted to sinus rhythm. Basically, actually, we cardioverted the person, went to sinus rhythm, went to VT again, cardiovert again, ultimately ended up putting this patient on amiodarone to control it because she kept going back and forth. Ejection fraction was slightly depressed, which subsequently improved. And she basically had idiopathic VT.
Sir, can I ask you a question?
Yeah.
So in the previous ECG, the white complex tachycardia ECG, is it possible to have anything other than VT if we have totally positive QRS in AVR and inferior axis? Is it any way possible to have supraventricular tachycardia with totally positive AVR and inferior axis?
Well, the problem with theoretical, hypothetical discussion becomes very difficult. We need ECG to look at. So to make it life simple, we have to follow a pattern. But if you find this pattern, this ECG basically is fulfilling multiple criteria of VT, AV dissociation, morphology criteria for V1 and V6, and that's fairly pretty good. And then this patient also had, when we had the patient was in sinus rhythm, basically sinus and goes into non-sustained VT. So this question ECG has no question about that. So how about this one? Go ahead. Somebody else had a comment? Tushar?
Abdul, please keep a poll.
No, I know. Anybody else had any comment? No. Okay. This is the next one. So this one is a good split, sinus tachycardia with sinus arrhythmia, and then atrial fibrillation, nothing else. Okay. So, I mean, very irregular. And so I'll call it atrial fibrillation with STT wave changes. Can it be atrial flutter with variable condition? Yes. Can it be sinus tachycardia with sinus? Very unlikely, even though there is something like, if you look at here, it looks like a P wave. I mean, it's so irregular. And then sometimes you see these things. This patient actually was a little bit more complex than what we thought. So this, but if I have this ECG, I'll call it atrial fibrillation. So look at what happened to this ECG patient, that a little bit later, this is the ECG again. And now I would like, same patient. So what do you think of this? Paul, please.
Kamal bhai, please give poll.
Okay. So 12 people answered. 4 said atrial fibrillation, 4 said SVT, 2 flutter, and 2 sinus. Okay, so I'm going to start with the discussion. First of all, when you look at the ECG, we want to say...
Sir, this ECG is too smart. There's a regular pattern, and look at the rhythm strip. It's a very sharply appeared ECG. We just look at the ECG, and the negative so-called T waves, they're too much regular, and looks like atrial flutter actually.
Okay, so what I was trying to say, Wadud, is it is whatever it is not atrial fibrillation. Do you agree with that, Wadud?
Yes, sir.
Yeah. So my comment would be that whatever it is not atrial fibrillation. It is too regular. So, and now between those, I have choice of sinus tachycardia, supraventricular tachycardia, atrial flutter, and all those are reasonable choice. But the question would be, if a patient is lying in bed, why will there be sinus tachycardia suddenly? I mean, patient will have to be hemodynamically unstable, should have fever or something to have sinus tachycardia. So most reasonable choice in this patient is atrial flutter. But if somebody calls it SVT and sinus tach, I will not totally rule it out. I will not fail somebody. Now, one of the questions that Tushar asked, what happens if the ECG diagnosis is wrong? Look at this ECG. It doesn't matter what you diagnose. Your wrong diagnosis will not kill the patient. However, when I had a patient with ventricular tachycardia, my wrong diagnosis can kill a patient. And that's where the importance is, like acute myocardial infarction. If I consider pericarditis as acute myocardial infarction, I am not harming a patient. However, if I miss acute MI, I am harming a patient. And that's the only scenario where in America, when there is exam, only time you get negative marking in ECG is when you have killed a patient. So this is most likely atrial flutter. That's my view. If you challenge me, I can't defend it because I don't have any other ECG of this. And then this patient, so I'm going to discuss, this patient actually was very interesting. So during rhythm strip, there is sinus rhythm, and then there are waves here. And I have magnified this image. If you look at this ECG, number 1 is sinus. 2 is sinus. And then there is supraventricular premature beat, which is upright, which is inverted. So basically 2 different forms of atrial beats. And then over here, you can see that is atrial flutter. So this patient had actually a mixture of atrial fibrillation, atrial flutter, and then atrial tachycardia. It's a complex patient, but it's very, very important to identify this, because if it is atrial fibrillation or flutter, patient needs to be anticoagulated. That's the key part. And the same patient, now tell me about this one. What is this?
Sir, just a question for
Yeah.
the atrial flutter. If it is atrial flutter with a regular 1:1 or 2:1 conduction, do we
Yes.
need to anticoagulate the patient?
We do. Many, many years ago, we did not anticoagulate atrial flutter. And nowadays, we treat them same as atrial fibrillation, especially in elderly people. And as you see, this patient actually is going back and forth between atrial fibrillation and flutter, mainly because, so as far as stroke risk is concerned, we don't differentiate at the moment, in the beginning of the diagnosis. Okay. Yeah. Any comment? So one person says sinus rhythm with short PR, ectopic atrial rhythm junction, and nobody says atrial fibrillation, which is good because it's very regular. Any comment from any panelist or faculty, please?
Atrial fibrillation can present with regular rhythm only when there is complete heart block.
Yes.
You should always remember that.
Yes.
Sir, my point of concern is that the PR, that PR is too short to have to produce QRS.
So you don't think this is conducted?
I think it's conducted.
That's LGL.
Okay. Well, let's look at sinus rhythm with short PR interval, unless it's low in Ganglion. But look at the P wave. It's inverted in lead 3 and AVF. So if I have an ectopic beat coming from near the AV node, it will show up as inverted P wave in 2 and AVF. And that can have a short PR. Other possibility, of course, is junctional rhythm. If there is a retrograde, which can actually come sometimes before or sometimes after, depending on AV conduction status. So these are the 2 possibilities in this ectopic atrial rhythm versus junctional rhythm. And my bet is probably ectopic atrial rhythm, because lead 2 is not negative. And so between the 2, it's not sinus rhythm with short PR, it's not atrial fibrillation. How about this one? Paul, please. These are all real-life ECGs from our patients, and you will get ECGs like this in real life. So that's why these are so important. I mean, these are not dramatic ECGs, but this is what we encounter in everyday practice. Okay, that's nice. 6 people answered atrial fibrillation, ectopic atrial rhythm, sinus bradycardia, atrial flutter. Okay. Any comment? So basically, it's artifact in the baseline, no question about it. So it's not a field.
Can you make a comment?
Go ahead.
Whenever we look at atrial fibrillation, we should look for 3 things. 1, is it real atrial fibrillation? If so, what is the rate? Again, is there any clue what could be the underlying cause? 3, is there any other a sign of chamber enlargement or ischemia or any sign of drug toxicity, etc.? Now, this is an atrial fibrillation where the rate is low. And we do not see any sign of that suggested dioxin toxicity or something like it there. We do not see any signs of ischemia. We do not see any chamber enlargement, except that there is a left axial rotation. And what could be the reason for that? We can make a story out of it.
Yep, so left axial deviation, but look at that. If you look at here, it looks like fibrillation, but look at the rhythm strip V1. If you keep following it, it becomes clear here that there is a P wave, and P wave is biphasic, positive P in the beginning and negative. So my diagnosis is sinus bradycardia with sinus arrhythmia. If somebody calls it ectopic atrial rhythm, I will not object to that, but it is not atrial fibrillation. It is not atrial flutter. So it's basically baseline artifact. A lot of patients have that, people with Parkinsonism or just electrode placement is poor contact, thus can cause artifact.
So for this, if we can zoom the rhythm strip, that clears the picture. Otherwise,
Yeah, look at the V1.
Yes, sir. Yes,
Yeah.
V1 and also the rhythm strip also, the lead 2. If we can zoom, then we can see clearly before each QRS. And the PR is variable sometimes. That is the sinus arrhythmia is there.
Yeah. Lead 2, actually, if you expand it, it will become a little more confusing. But V1 is it clears at the end of the tracing. You see over here, you can see the P wave, QRS complex, there's first degree AV block. How about this one? Poll, please. Okay. So we have everything. Atrial fibrillation with rapid ventricular response, sinus bradycardia. Aha. That part I will kind of object to. I put it for the fun of it, but the heart rate is 132. So if this is in the exam, whatever you do, nobody should have answered sinus bradycardia because it is not bradycardia. Anybody, faculty, any comments, please? Wadud? Can you hear me?
Now I can hear you actually. I have a rather unstable connection.
Yeah. So a couple of choices were sinus bradycardia with sinus arrhythmia. I think maybe they mispressed the button. It's not bradycardia, that's what I was talking about. So do you have any comment about the ECG, please?
Well, a 60-year-old person, female, and the rhythm is slightly irregular, but in V1, we seem to see some similar looking P-wave like waves in between a little bit disturbed. In V3, there seems to be a what? Like a connection to the oscillator.
Yeah, as Professor Chowdhury was mentioning that maybe something looks like this. The reason I put this one, when atrial fibrillation gets faster, it becomes a little difficult to appreciate the irregularity of the RR interval. But look at this now. So I have put this whole ECG now, it becomes more evident. So now can we do the poll again, see what everybody else says? Everybody says. Can I have the poll, please? Yep. So majority said atrial fibrillation, and then atrial flutter. Yeah, it's a possibility because you see some places it looks like flutter. I mean, if you look at lead over here, kind of flutter looking, but sometimes there is this also like over here looks like flutter, but across the board, if you look here, over here, here, it's basically atrial fibrillation. Sometimes you have coarse atrial fibrillation. This is the term that we use, and the signals can look like flutter. So basically, it's atrial fibrillation with rapid ventricular response and maybe atypical flutter.
Sir, is the term flutter fibrillation spectrum used now?
Yeah, we use it, but I'm not sure it's big because there are patients who have both. Or in one rhythm strip, you can find that there is fibrillation in the beginning, flutter. Actually, as a matter of fact, we used to record intracardiac signals with Holter many years ago, that we'll put a catheter in the coronary sinus and connect it with a Holter monitor. And you could find that right atrium is in fibrillation, left atrium is in flutter, a pretty organized way. So yes, that term is used, I'm not sure. But if you use the term flutter fibrillation, basically you treat that person as atrial fibrillation rather than atrial flutter. How about this one? Look at the rate. I put the rate here, 109 beats per minute. Okay. Atrial fibrillation and atrial tachycardia. Sure. Any faculty, any comment on this, please? So it's fairly irregular. And so
দেখতে স্যার দেখা যায় তার কিন্তু V1 এ 1 2 3 4 5 এখন থার্ড ফোর্থ ফিফথ এর আগে পিএব এর মতো মনে হচ্ছে।
Yes. Yes. So but Professor Chowdhury said that here in lead V1 there is a P wave, there is a P wave. Is there a second P wave? Maybe. I always entertain that idea, but as it is irregular, if somebody calls it AFib, I will not wrong that person. I will also entertain the diagnosis of atrial flutter with variable AV conduction versus sinus arrhythmia. So let's look at what happened. So this is what we are talking about. So when we did a long rhythm strip, we could find places where it's slower. And here you can see clearly the flutter wave. It's atypical atrial flutter. What is the difference between this and atrial tach? It's basically semantics. If somebody calls it fast atrial tachycardia, I will not wrong that person, but that atrial tachycardia rate will be close to 250 beats per minute, which is very unlikely. So it's most likely atypical atrial flutter. with variable AV conduction. So when you get an ECG, you have to get a rhythm strip. One ECG may not give you the answer, and you cannot just give up oh, this may be this. So you have to have a diagnosis. So when patient converted to a regular rhythm, probably an ectopic atrial rhythm. I'm going to move on to this. So similar ECG. So this one. And when we put questions, a lot of times, even if you don't know the answer, correct answer, there is a clue in that choices, which we put in on purpose so that if the person cannot get the diagnosis, by that clue, they may be able to get the diagnosis. Aha. One person answered, so it's 100%. So these are all the possibilities. Tachycardia regular cannot be atrial fibrillation. As Dr. Prasad today said, if it is slow and regular, let's say 40 beats per, can still be AFib due to complete heart block, but a tachycardia with a regular cannot be atrial fibrillation. It can be supraventricular tachycardia, can be atrial flutter with 2-to-1 conduction. It can be sinus tachycardia because the rate is around 143. And also there is a P wave. One of the things, I'm going to come back to this. The clue here was there is left anterofascicular block. I did not put this diagnosis with anyone else, any other choices. And you will find that in exam questions, there are clues that the examiners will put in. So please try to identify that clue. Only one diagnosis had left anterofascicular block. So this is, if you look at the heart rate, 143 at 9:44 a.m. And I always talk about that at 10:27, heart rate is 143. So basically, the heart rate haven't changed close to an hour. When the heart rate remains constant, it can be anything except sinus tachycardia, because sinus tachycardia will not stay in one place. It will go up and down because of the intrinsic sympathetic tone, vagal and sympathetic nerve stimulation. So this cannot be sinus tachycardia. And then when the rate slowed down, you can see that there are these flutter waves that we can see. How about this ECG? Can we have a poll, please? Okay, nobody said atrial fibrillation, that's fine. It can be ectopic sinus rhythm with sinus atrial flutter with 2-to-1 conduction. Okay, and of course, just to have so that these waves, but kind of what is bothering me with looking at this tracing, that if this is flutter wave, what is this thing? Same here and same here. So there is a little bit funny thing going on, but if I add I took this thing off, if you look at now, your thing will change. Look at lead V4 and V5, there is clearly P wave. So it's basically a baseline artifact. And when you write the ECG, you should make a comment that baseline artifact, but it's a sinus rhythm with baseline artifact. How about this one? Poll, please. This is the telemetry rhythm strip.
And how was the patient at that time?
Well, we're going to answer that when, let's look at the poll and then we'll answer. Yeah, okay.
Look carefully on the rhythm strip.
Yeah, so yeah, one person said artifact, everybody else said ventricular tachycardia. Yeah, so Tushar asked a very appropriate question. Even if you diagnose this ventricular tachycardia, first thing you go and ask the patient, how are you doing? If the patient is smiling at you, it can't be anything other than artifact. So please remember, when you see this ECG, if you go to the patient, first thing you ask the patient how the patient is doing. But look at carefully. In this strip, there is something there which is coming at a regular interval. And this is actually, this ECG or similar ECG will always be given in the board exam. Because as Tushar said, sometimes there can be reflex thing that you go without even talking to the patient, shock the person. And they have done it because some patients have defibrillator pad put in the chest. And then, of course, I removed actually one of the rhythm strips on the top. At the top, one of the strips was actually very clear. So this is not uncommon, and it is also not uncommon patients getting shocked because nurses or doctors thought that, and also generated electrophysiology consult to diagnose. So this is the artifact.
Just a question. If someone inadvertently gets DC shock, what are the adverse consequences?
Oh, so the question is, if you give DC shock, most of the time, because people will consider this as ventricular fibrillation, and they will give the patient shock. First of all, it is painful, and that patient will probably never come back to you. Second, you can actually, if you give an asynchronous shock, which should be done if it is considered VF based on this rhythm strip, then you can convert this person into VF. Remember, if you have shocked somebody and put them into VF, what is the next thing you do? Next reaction for you is to run, but don't run, charge the device, give another shock. That's it. And the patient will go back to normal rhythm. Tushar?
Yes, sir. Totally agree with you.
Yeah. I think we should stop here, right? It's 10:30 now. 9.
Thank you, sir, for the excellent practical demonstration of the ECG and explanation. The most important thing you have discussed, if we get it wrong, what may be the consequences? Many times we may not reach the actual thing, but if we do inadvertently wrong thing, the consequences will be totally hazardous sometimes. So as you always say, if we can't help a patient, we have no right to make it worse.
Right.
Adit sir, are you here with us? Adit sir?
Ajit, can you hear me?
Yes. Actually, it's a nice discussion. I heard everything. Though I was still working on I'm on call. Okay, I'm writing some notes, but it's a nice discussion as always. And the artifact that you saw, it's very common. You get called.
Yes.
And look at that rhythm history is very important. You'll see, if you carefully look at it, you'll see certain area, very regular, normal QRS you can see in between. And particularly if you look at that, like from 1, 2, 3, 4, fifth row, you see the R wave. You can see certain level. You see that in VFib, you will not see that. Okay. And when you see those, like on the 6th row also, R wave, they're coming in regular pattern. That alone tell you that patient is probably moving something or something motion artifact going on. It's not true VT, but we get called for that.
Jamil sir,
Yes.
sir, your comment on the ECGs and the discussions.
It was excellent discussion and very much practical oriented. But when there is tachycardia, it's often confusing whether it is atrial fibrillation or atrial flutter if there is variable block with flutters. And so the flutter fibrillation together comes in the diagnosis. And Rafique sir has rightly shown those things, especially those become conspicuous when it is zoomed. Thank you, sir, for a nice presentation.
Thank you.
And lastly, I'd like to request Professor Abdul Chowdhury sir to pass his comments about the presentation, the discussion, and conclude the session. Wadud sir.
Actually, these sessions become entertaining. Why? Because they contain not only knowledge, but those knowledge are based on down-to-earth situations, real-life situations that we are seeing in day-to-day practice. And these things, these small pieces of knowledge actually help us to decide in the practical life what to do, what not to do, how to approach. And that they become very much helpful. And Rafique sir is a very expert in that, making complex things simple or making things very much related to the real life situations. And these things we can remember for a long, long time because we are seeing them all around us in our day-to-day practice. Thank you, Rafique sir. It was really entertaining. Really, I would say we have learned a lot from you. Thank you, sir.
Dr. Ahmed, I have one question. I think that's the one that we did on the VT with retrograde, some sort of conduction that we talked about. But definitely the if there is no R wave, so in V1 lead, if the first R segment was smaller, then I would have more favored for, right bundle branch block, because retrograde P wave, because I remember that you showed us long time ago later diagram in the AVNRT, because sometimes it can be blocked. And if you see that, that means it needs the AV node to have to complete the reentry.
Exactly. Yes. Absolutely. So in this case, the first R was bigger than the second R. If it was the other way around, it would have been supporting SVT. As I said, AV node reentry can have antegrade block. It is very rare to have retrograde block because there is not much tissue to block. Because AV node and next is but antegrade, you have the His bundle and it can block somewhere in the His bundle. So there is enough tissue to block. Thank you. All right. Thank you all. Good night.
Thank you, sir.
Thank you. Thank you.
Yeah, there is a question.
Riti, keep on going.
কোশ্চেনটা হলো যে ওই যে লিড 2 তে হলো যে পি পজিটিভ ছিল কিন্তু 3 তে আর এভিএফে হলো গিয়ে পি নেগেটিভ ছিল ওই জন্য ওইটা একটুপিক এট্রিয়াল রিদম কিন্তু যদি 2 তেও পি নেগেটিভ থাকতো তাহলে ওটা জাংশনাল রিদম হতো এরকম কেন?
Oh, so the question what I was trying to say that junctional rhythm usually there's a retrograde P wave would be prominent in all the leads, 2, 3 AVF. Is it always true? No, but most of the time, because it's coming from inferior. But if it is ectopic atrial rhythm, which is a little bit on the left side, because lead on the right side, lead 2 is on the left side. So if there is ectopic atrial rhythm just a little bit on the right side, then the 2 can become flat or biphasic. Thank you. Thanks for pointing that out.
Thank you, sir. Good night.
Take care. Okay, bye-bye.
Thank
for
you.
every participant. Thank you.
Thank
And
you,
all the
Dr.
panel.
Nice to see you.
Thank you all. And we'll be in after 2 weeks. Good night.